Thank you everybody for joining and welcome to this Lunch and Learn. So this is going to be the first of a number of Lunch and Learns that we're planning to hold over the course of the next few months in different areas of our digital first program and looking at different ways we can share good practice, learn from each other, and try and answer some questions that come up regularly, but do it as a region and as a wider group. So welcome to everybody. Really grateful to have you all here. And just a quick intro from myself. So I'm Roman Patria. I am a senior program manager within the Digital First London region team, and I lead on digital access, collaborative hubs, the change management side of things. So this is the first Lunch and Learn that we wanted to do, which we wanted to look at online consultations and some of the good practice that is out there already, and how people are using the online consultation tools successfully, how they're managing patients and their demand, and look at some of the aspects of online consultations, how it's going to help us reach some of the priorities of the access recovery plan as well. We really feel like online consultation can support some of that, tackling the 8 a.m. rush and reducing the number of telephone calls, or the people that do need to speak on the telephone can actually get through, and how online consultations support that. Could I just ask all guests to just go on mute if possible? That'd be great, thank you. And managing the urgency of ensuring patients get to see the right clinician as much as they can as well. We feel that online consultations definitely help support this, because you're able to see the type of queries that are coming in through the consultation system, and then you're able to direct that to the right clinicians as well. And it's also utilizing the R's roles more successfully as well. That's just a really quick update from myself and a quick intro, but I really want to just ensure that our guest speakers today are able to use their time more than me rambling on. So I will hand over to Devin Gray and Anushka, who are from the Southwest London Putney Mead practice. Yeah, I'll hand over to yourself, Devin and Anushka. If you could quickly introduce yourselves, and I'll let you control the slides. I'm sure you've got them there. And then we'll hand over to Ishvia, and then we'll do a quick FAQ Q&A at the end of the session as well. So over to you, Devin and Anushka.
Thank you. And just to let you know, since the meeting went live 5 minutes ago, our connection has dropped twice. So I'm not sure if that's us or you, but if we do disappear momentarily, we will be back. If all goes wrong, I've emailed you the slides, Roman, and we can join on my phone. So that's the backup plan. So my name's Devin Gray. I'm a GP at Putney Mead and clinical lead for the Digital First programme for Wandsworth.
And I'm Anushka, and I am the reception and patient liaison lead at the practice and deal with most of the non-clinical workflows.
Brilliant. So between us, we hope we'll be able to cover everything. 15 minutes is a very tight slot to tell you everything that we have learnt. We've now been doing patient triage with Accurix for 26 months. So there's a lot of learning, and my approach has been to put as much as possible in the slides and whiz past them, so that you can, if there's anything you want to know about in more detail, you can kind of go back to the slides that have got lots of detail in them, but we're going to try and cover it as quickly as we can. So I'm just going to get the slides up. This is what we're going to cover very ambitiously in 15 minutes, and we also want a chance for you to ask us questions. Just to give you a bit of context, Putney Mead is a large practice in Southwest London. We have nearly 26,000 patients. You can see from our demographic there that we're mostly working aged adults, and we have a relatively low deprivation scale. And the context for us was that we were in the middle of the pandemic. Patient feedback on access had always been relatively poor compared to the rest of our access, our feedback, and that was not so relevant during the pandemic when everything was total triage on the phone. But we had been considering online consulting for a while. We did have Dr. Link on our website with very minimal uptake. We introduced online consulting at a time where life was already very disrupted, because we had already switched off patient access because we were doing total triage over the phone. And so that in some ways made it an easier time to introduce change because things were already kind of turned on its head. So this is what life was like before we launched. I'll just giving you some numbers there on the left, which I'm sure represents, proportionally what many of you would have been dealing with anyway. But the main problems on the right there is that GP appointments were often booked for minor issues. We had lots of chasing referral appointments, or requesting blood forms, or routine medication requests, basically things that could be better done by someone else. And we felt our patient access system really suited particularly young and more tech savvy patients. We would release them the evening before and early morning, and those appointments would get mopped up by people who knew how to play the system, leaving people perhaps more vulnerable or less technological trying to get through on the phone. Why Accurix? We were really trying to consider what tool would be most appropriate for our population. And in general, the average patient here would be able to summarize themselves what the issue was in a small free text box. And we felt they wouldn't really take to more questionnaire style approaches. We were familiar with the platform. We were all using it a lot during the pandemic for video and SMS. We were very keen that whatever solution we had integrated with EMIS. Accurix had a good reputation, and there was a free trial on offer for 6 months. And so we just took the opportunity right as the COVID vaccine rollout was starting in January 21 to do it. But we did look at lots of other options, including footfall, and the partners at Putney Mead had been visiting other practices for a couple of years before the pandemic really sort of had been on their mind to do this for some time. And this is what we wanted to do. We wanted to improve the fairness of access. We wanted to prioritise appointments based on clinical need, and we wanted to use our multidisciplinary team more effectively. So we kind of came up with this probably well-used phrase elsewhere: right person, first time. The convenience comes with a caveat, because people did find patient access, the app, very convenient, but we wanted to improve convenience of access across the board whilst trying to hold on to continuity of care. I'm not going to go into the details about how we planned it, and I can share a link to a webinar that I've done before, 45 minutes of how we did this in more detail. But we decided to do it 2 weeks before we launched. So it is possible to do it last minute, and we put a lot of work in those 2 weeks into the planning. We decided to go full hard launch with just a 2-week overlap on patient access, and by that I mean that on the day that we launched, we encouraged everyone who could use the form to use it. Patients were informed a week beforehand. I walked the floor all week. I wasn't in clinic at all on the week that we launched, and we weren't changing the templates. We weren't sort of changing how we were speaking to or seeing patients. We were just using it for triage. And we had scripts and FAQs for staff. I can share all the resources if anyone is interested, and kept everyone updated via email. This was what it was supposed to look like in theory, and then we will come on to what it looks like now. But just to get an idea of the flow, no matter how a patient would contact the practice, in theory, it would come into the Accurix box, be triaged by the receptionist, who would either request more information, respond and close the query if it was possible, make them an appointment, or reassign them to someone else if they couldn't answer their query or needed some kind of clinical input. And that was, we then knew that we would just be doing a lot of experimenting afterwards. And I will come on to what it now looks like. But first of all, I just want to show you what the first 6 months look like. This is all manually extracted data, because Accurix is still working on their dashboard. So you can download an Excel spreadsheet of the data, which I was then sort of analysing each week and turning into a graph. And funnily enough, the first 6 months is really when we saw the most demand. And the context for that is almost certainly the pandemic, because the COVID vaccine rollout was starting and absolutely everyone obviously wanted to know when they were getting their vaccine, what conditions they had coded in their record. You were there, you know the kind of stuff that we were getting, but we were getting lots of that through Accurix, which presented an opportunity because it allowed us to work out, you know, there were sometimes whole clinics that we put on, we just assigned all of these queries to one GP to work through, but the volume was higher then than it is now. So we had over 1,000 requests a week. The proportion of medical to admin has been absolutely stable for 2.5 years. So 60% medical, 40% admin is a very stable proportion. And what we very quickly realised is that having the form on 24 hours a day, 7 days a week was really inefficient. So we were very keen at the beginning to say, you can contact us 24/7. But it just didn't work. We were getting lots of duplication of work. So for example, on a Friday afternoon, someone would send a message, then it would get read on Monday, they'd be given an appointment, the patient would be called and they'd say, oh, I had my issue sorted out in the end of the weekend, I went to 111 or wherever it was. So we initially switched it off at the weekends, and then we later switched it off in the evenings, and that in total brought down the demand by 38%. Now, it's hard to extract what coming out of the COVID vaccine rollout also did to demand, but you can see a clear step change, and I can show you about that. This is just showing you a bit about, we extrapolated admin and medical requests, and there are two very different shaped curves. So the medical requests come in mostly in the morning and tail off as the day go on, whereas admin requests kind of peak in the middle of the day, and I'm envisaging people on their lunch break sort of sending a message saying, oh, I need my medication. So for practices that have either done one but not the other, so I know lots of practices are just using online consulting, for example, for admin requests, just be aware that if you do then open up for medical requests, the pattern is different between the two, certainly from what we have noticed. And our phones data is really hard to analyse because we don't have a smart cloud-based telephony system yet, and all we can see is number of attempted calls, not number of sort of new calls, new users. So you know, this was just a rough between December and January. We went live in the middle. You know, we think that call numbers reduced a bit, but it's very hard for us to actually see the impact on the phones. And Nuska, you can obviously tell us more about what the phones are sort of like in real life on that. Patient feedback, our friends and family feedback was very stable before and afterwards. It remains so. Accurix have a form at the end of the form, so the graph on the left reflects patients' response to filling out the form, but not the whole care experience. The only way of going to do that is to go and ask patients after they've contacted us and been seen what their experience was. And staff were actually have been positive about it. Anushka is going to tell us later about the challenges of getting the admin and reception staff on board. But we had feedback from the clinical team who really valued being able to see the patient's problems written in their own words, saved to the record before they called or saw the patient, and being able to, for really a training practice, we've got lots of trainees, and to be able to best meet the needs of trainees through them being able to select patients from the box, or just kind of being able to be seen by the right person first time, we've definitely noticed. So on broad terms, the impact that we saw was better use of our MDT, which is what we wanted. So our pharmacists, PA, we occasionally have an ANP, nurse, counsellor, psychologist, physio, social prescriber, big MDT team. We can much better ensure that the requests that come in are met by the needs of the best person. And we're using community services better. So if patients, you know, send an Accurix about conjunctivitis or, you know, earwax, the receptionists know all the services that they can first offer to the patient before offering them an appointment in the practice. We often close consultations without calls at all. The most common ones are people asking for blood forms, maybe something that's come through on the letter or something that's on the diary date. Med3 extensions where they've said, oh, actually my my surgery date's been moved back by a couple of weeks, and all the information is there and you don't need to call them. Referral redirections, or even just, you know, self-limiting or minor illnesses like warts, verrucas, things like that, to save an appointment's been great. We can choose when to action non-urgent activity. So before, we'd have that 8 a.m. rush, and in there would be someone wanting to change their address routinely, which is so frustrating when you're trying to triage. So now, you know, the non-urgent, non-clinical tasks can be saved for later in the day when the phone lines and accurates are quieter, and we have the ability to do that. And any remaining capacity or duty list can be reserved for the highest clinical need. So when the appointments have all run out, we're just looking at the duty list, and there's 100 requests in the inbox, the receptionist can, you know, whip through those and make sure that any last remaining appointment are allocated to those who really need to be seen or spoken to. What's challenging, and this morning's clinic is a great example of this, is if you do this really well and you get the triage right, all that is left in a GP clinic is the complexity that can't be managed by anyone else. And that's kind of what we've been aiming for, because we're trying to use the team as best as possible. But it's really important that I think that as an organisation that you consider the impact of that, and it's within your power to decide how you do that. So at Putney Mead, we have just dropped down to seeing fewer patients in the GP clinics and have 15-minute appointments to reflect this. I mean, it's been the case for 2 years, but that's where we've kind of finally come to it, and we're going to manage it as best we can. But be aware that if you do a triage approach and you do it well, then that is an unintended consequence of it. So where are we now? Data collection and analysis. We have objective data about demand, and I do want to reassure you, if you haven't done this before, it does not rise exponentially. Our demand is totally stable and totally predictable. The only spike that we get is if, when we were doing the COVID things, when there was a big COVID vaccine group announced, we'd see a big spike in demand, and there was about an 18% increase in that dreadful 2 weeks in December around Strep A, that you can kind of see the increase in demand. But apart from that, when you're having a rubbish day in general practice, you know, my colleagues will say, like, why are all the patients asking for appointments? And I will show them the data and say, there is not an increase in demand. We don't have enough capacity today. And that's why it feels rubbish. And that's been a really important kind of learning for our team, that and you can see it coming, you know, when capacity is going to be down. So actually, what can you be doing differently at 8 o'clock in the morning when you know that your capacity is not going to meet your demand? So we've had to think about overwhelm strategies. We have improved continuity, I think, and that's partly because the complex patients are more with GP, and there's a little box at the bottom of every Accurix request saying which clinician would you like to speak to, and the team will do their best to fit that person in. And we've got some data to show that more patient appointments are now being given to patients with long-term conditions than before, and the average age of a patient receiving a face-to-face appointment is older. So we do think that we've seen those improvements. I'm aware of time. This is kind of in many ways the most important part, and I want to just hand over to Anushka to rattle through what the challenges were and are.
Hi there. Sorry, I've got a bit of hay fever today. It's really important that you're honest with your team, honest with yourself about the impact that it will have when you bring it in. I think there was a misconception with the team here, especially in the reception team, that if they didn't like it, it would go away and they'd go back to how it was before. I don't really understand where they got that from, but it was a misconception that was actually blocking, you know, effective change management, because they felt that if they pushed back, it would all go away and everything would go back to normal. So just be extremely honest with a team when you're bringing in a new system like this, because it has shown to be a godsend in many ways with the way that we do the certain bits of work. So being able to text patients rather than trying to hold on and get hold and ring them. When you're doing admin work, when you're doing, you know, you just want to know if someone's up-to-date address is correct, you send them a quick text, you get a response. It actually has managed to improve the flow of work in so many different areas, but they can't see it. You have to do it to understand it. So you do have to kind of sell it a little bit, and there does have to be a leap of faith, and that they have to go, right, that this will give us these benefits, but they won't see them until you actually go on that journey. Be very aware you will have to have an overwhelm strategy. If you've got 3 receptionists that call in sick, there is literally nothing you can do about it, and you are going to have to know how you're going to manage the phones and the accurate and the online consults coming in. You have to be honest with yourself. You are not going to you don't save capacity on the non-clinical side in any way, shape or form. It's just been switched out. So I effectively have had to take it's 1.5 full-time equivalents really, to cover Accurex all of the time, and those people then can't be on the phone. So you don't really save anything, but it does help for workforce planning. And like Devon was saying, you can push work to the back end of the day when you know the phones are off, and we actively have a box where, you know, routine admin requests go in and they get accessed in the evening. We still have a 24-hour or we aim for a 24-hour response, but if you can't get that response back to people, then you've got control over how you respond to them and tell them when we're going to get back to them. But it's going to be vitally important with the new contracts and being, you know, having to plan your workforce and show that you're planning your workforce. This kind of data shows you exactly where you can put people and when. You have to be careful not to get, we unfortunately, some people are very good at using these systems and some people are not as fast in the way they process. You tend to start to rely on, you know, super users, as it says on the slide, and you can become a bit over reliant on those, and you've got to be really careful to keep the workflow spread amongst a wide enough members of the team, so that when you've got holiday and illness, you're not suddenly then scuppering around going, why is Accurex on 100 and why has it not been dealt with? And you kind of have to watch it all day, every day. It is on my desk every day. Even if I'm not looking at it I will have to check in every hour, because you need to keep an eye on where it's at, what it's doing, and because it's like, as you would with the phones, it's another work stream that you are going to have to watch. So that is the main things that you're going to really need to be aware of.
And the just 2 really important things I want to cover is, I think the real gritty questions here are clinical triage. So what Anuska is explaining there is that we have a predominantly reception-driven triage system, and we've supported them with training to do that. And then we have a robust escalation policy, and I'm going to show you what that looks like. So at the moment, and we've iterated this lots of times over the last 2 years, but essentially the receptionist will manage the triage as if they were over the phone. But if they are unsure of the urgency of the request, or are unsure of the best service for it to be seen, or there's no capacity that they think it needs to be seen urgently, they will assign that request to the doctor's box. The duty doctor has the doctor box open as part of their session, and they will do a quick comment on it and then send it back to the assigned to box. So they will either just close it and say, yeah, and just give advice to the patient directly, or they'll say, please squeeze in urgently to the duty list, or please offer the next available face-to-face, or this is routine, the abdo pain's been going on for 2 years,
or go to A&E,
or whatever it is. So this, again, you'll be able to look at this in more detail, but this is what our clinical triage currently looks like. And you know, we're maybe transitioning to total triage, because at the moment what isn't working, because it's not perfect yet, is that we're really good at triaging the Accurex box, but what comes in through the phone is probably not being as robustly triaged. If there's an appointment and the patient wants it, it basically just gets slotted in so that they can get on to the next call. So we're still working on it, and we might move to a system where even the phone call gets turned into an Accurex and ends up in the same box. This is what I want to just show you. This is over 2 years worth of data, and this is 18 months of total stability. Those big drops are bank holidays, and that spike there was, I can't remember what that particular one was. It would have been something
Booster.
in the news, maybe booster program. Yeah, it could have been boosters, but it's really, really stable. And I also just want to show you, this is what Putney Need looks like in relation to the rest of Southwest London. So if you just look at the light blue curve, it looks like demand from OC is going through the roof, but that's just practices switching it on. And if you look at the bottom, how at the beginning, because we were one of the early adopters, we formed most of it. Again, you can see how stable that demand is, even though practices are continuing to put it on. Access, just sharing that slide with you around how patients are accessing us, whether it's by proxy and long-term conditions. And this is our sort of performance. So we turn around, our average turnaround time is 2.7 hours, but we advertise a 1 working day to be interpreted as patients want to, but basically it's a 24-hour turnaround time for routine. If it's urgent, we'll get back as soon as possible. So I will leave these slides about our success factors, lesson learned, and where are we going next, because of time for either you to read or to come up in the Q&As. And I just want to hand back to Raman for the next group.
Thank you so much, Devin and Anushka. That's really, really helpful. And yeah, really good to see that, you know, and the honesty about that. It's not the silver bullet. It does a lot, but there's still some challenges in there. That's really helpful to see. Okay, thank you. So mindful of time, I will pass over to Ishvia, who's from the Southall Medical Group. Ishvia, I'll let you take it away if you could do a quick intro, and any slides you've got, feel free to share them yourself.
Yeah, that's great. Thank you, Raman, and thank you to Devin and Anushka. Because I'm going through my presentation, I'm seeing that there's a lot of similarities. So hopefully we're seeing the same benefits and challenges. Okay, can you see my slides?
Yep.
Ishvi, you're quite quiet. I don't know if it's just me.
Can you hear me now?
That's better.
Yeah, thank you.
Perfect. I'll try and speak a bit louder. Yeah, so my name is Ishvi and I'm one of the practice administrators at Southall Medical Centre. And as Raman introduced, we were just asked to look at how we've been implementing online consultation within our practice, sort of how we launched it, and then some of the benefits and challenges that we've seen over the coming up to 3 years now that we've been using eConsult. So as an outline of what I'll go through quickly, I will give a bit of a background to our practice, a bit of an idea of how we were doing triage pre-pandemic. Then I'll talk about eConsult and the process of triaging eConsults within our practice. And then I'll look at the advantages that we've seen and the benefits, and then some of the challenges that we're still facing now. And then hopefully give you an overview of some data and statistics, although that's a bit limited based off what we can see based off the data that comes from eConsult. And then I'll be happy to take any questions at the end. So just as a background to our practice, we have approximately 9,000 patients in Northwest London in Southall, and we operate over 2 sites. So we have a main site and a branch site. We have a full complement of clinical staff, so a good skill mix of GPs, nurses, clinical pharmacists, and a full administrative team. And then via the PCN, we also have access to a number of ARRS staff, so social prescriber, first contact physiotherapist, paramedic, and more clinical pharmacists. In terms of our patient profile, the majority of our patients come from an Asian demographic, so 90% have an Indian, Pakistani, or other Asian ethnicity. And of these patients, the majority don't speak English as a first language as well. And this was, one of the major barriers that we faced when looking at a digital online consultation approach and what would work best for our patient population. So pre-pandemic and looking at the ways patients accessed appointments at our practice, we noticed, or we highlighted, that there were access issues. Patients would report that there was high demand on the telephones, especially on Mondays, especially after bank holidays. And we needed a solution or an approach that would improve the patient experience, make it easier to access those appointments, whilst also making better use of, as I said, those ARRS and the allied staff that we now have access to via the PCN, but also the community services that we thought were being underutilized. So the local pharmacy, the optician, the dentist, and so coming up with a more robust triage approach, and also making use of the digital approaches that were coming out via the CCG. So eConsult itself is the provider that we used, and it's accessed for patients via the practice website. Patients essentially will submit an online form, and through eConsult, their built-in response rate is essentially requiring a response from the practice by the end of the next working day. So it's not quite 24 hours. If a patient submits a form, say on a Wednesday, then by Thursday at 6:30, they should have a response from the practice. Similarly, if they submit a form on Friday or on a weekend, then they'll need a response by Monday at 6:30. And parents and carers or other relatives are able to submit forms on behalf of patients. And based on what patients have reported and our experience of using it, it takes only 5 to 10 minutes to complete the form. So it's fairly straightforward, and it's quite simple or easy to use. It's been designed to be easy to use. And it looks something like this on our practice website. It's very clean interface. You can go through different health problems. As you can see, it's split into adult, child, and then there's an administrative section, and then a section there for long-term condition management as well. So when we were looking at implementing a digital approach and how we would train and upskill our team to use this service, which was commissioned by Ealing CCG at the time, there are still a number of remote training resources from eConsult and videos from the clinical leads there. So if you're a practice looking to use digital services more or to implement a patient triage model like this, then definitely make use of these resources. Similarly, from our CCG and North West London ICB, there were a number of videos on how to use eConsult, and there is integration of eConsult with System 1, which made it even better for us to use as well. Similar to the ways in which hospital letters are received or NHS 111 letters, eConsults come directly into System 1, which means our admin team and our care navigators can action those tasks and triage it to the relevant clinician within System 1 without having to download and import them, which can basically add extra admin time. We provided training to our care navigators and reception staff. We had to have a number of practice meetings before launching, so our staff would be aware of how the system would work from the patient perspective. And it was a rough start to begin with, so we learned a lot from using it, and we've had to adapt it quite a bit based on what we think is best for our patients. And following on from that, we've also got our own in-house triage process and our local standard operating procedures, our SOPs, based on what works and what works for our team and also what works best for our patients. In terms of getting patients on board, this was probably one of the biggest struggles that we had, and one of the biggest struggles that any practice that's going to adopt a digital triage will face, because patients are very used to calling up the practice or coming in and leaving with an appointment with a doctor. And when you tell them that they'll have to now go through an online form and wait possibly for a day to hear back from us, it can be quite frustrating for them. But I think once they've used it and they've got used to how it works, your patients will start to see the benefit of it. So we started obviously by advertising the service. So we made it clear with signage, we promoted it clearly on our website, but possibly most important is the guidance that comes from your frontline reception staff and our practice team. So like I said, we had a number of meetings with our receptionists and our care navigators, and they were the ones essentially who had to teach patients how to use eConsult, what was appropriate for eConsult, and still adopt a certain amount of their own triage. So if patients were coming in with your normal dental issues or eye problems, not to use eConsult, but still go to their community services, and that's something that we're still encouraging today. And then finally, promotion of the online consultation tool on the telephone line. So this was one of the biggest issues that we had. Most patients would be ringing in the morning. There'd be a long queue. But if you're able to add in a prompt there that says, you don't need to wait in this queue, you can go on our website and you can fill in a form and hear back after a day, then a number of those patients, they will hang up and they will go on the website and fill it in, because they know that they can access that straight away rather than wait for someone or wait to hear from a receptionist on the telephone. And it frees up that time so that the receptionists are able to deal or handle those patients who are digitally excluded, or who may not be able to fill in an online form, and so they have more time to help them. So the way in which e-consults are processed within our practice, and this is very simplified overview, and there's a case study at the end of my presentation which goes into a bit more detail, but essentially the patient will complete the e-consult on the website and they're received, that comes straight into system 1 within about 15 minutes. Like my colleagues said earlier, those e-consults do need to be looked at and managed throughout the day. It's not something which can be done just at the end of the day to process them all in one go, because they'll be received constantly, and to make sure that they're being triaged within the right time frame, to make sure it doesn't get out of hand. You do need a designated administrator who's going to be processing those e-consults. Those e-consults typically get passed on to our duty doctor, and our duty doctor will triage those e-consults. And this comes into one of the challenges which I'll mention later on about the time that it takes, that you now need a clinician who is going to triage all of these e-consults. And depending on the triage route, either an appointment will be booked with the relevant clinician, it may be triaged to a community service, or a very small number of e-consults may be closed remotely. So if a patient's asking for a repeat prescription or an administrative request, then we may be able to close that without having a patient contact, but only in a very minimal number of cases. And then the final step is potentially the most important, is where our care navigators will then go back to the patient who's filled the e-consult and advise them of what's happened. So although we'll keep patients updated throughout this 5-step process with, regular text messages, it's closing the e-consult at the end which is most important, because that needs to be done, like I said, within the 24-hour time frame. So our reception team will advise a patient that they've been booked in with the GP, or that they've been referred to a community service, and advise the patient. We've seen a number of advantages to using e-consult, and the first advantage, or the most important, I think, is regulating the patient demand. So our e-consult service used to be open 24 hours, 7 days a week, and although this was work suitable in the early stages when we weren't receiving as many e-consults, now that it's become the front door, the digital front door for our patients, almost all requests for an appointment are coming through e-consult, and it's impossible to maintain that or to regulate that demand if it's 24/7. So our e-consults are available between 8 AM and 5 PM, Monday to Friday. And what that means is it gives patients flexibility, because they can submit an e-consult any weekday, and up to 5 PM. After 5 PM, it allows the duty doctor and the reception team to ensure that all the e-consults that have been received that day are triaged, so that we're able to meet that time frame, the 24-hour time frame. And what it's done is it's essentially, or we hope it's reduced that Monday morning rush, which I think we were facing pre-pandemic. But I have put an asterisk there, because although the requests for an appointment are coming now via a different route, so although they would come via the telephones before or face-to-face, they're now coming digitally through e-consult. We do see the most number of e-consults will be on a Monday and a Tuesday earlier in the week, following the weekend. After a bank holiday, for example, the Tuesday is going to have a high number of e-consults that week, because it wasn't available earlier, and because patients, there's always a rush on Monday. But it does allow the practice to have the flexibility to book the patients in later on in the week. It means we're able to offer appointments 2 weeks in advance. We can triage those basically, and it's given us flexibility to ensure that those with the greatest clinical need can be seen earlier, and if a patient's coming in with a routine problem, they can be booked in later. Making every contact count as well, so the opportunistic care provision has also been great. Whenever an e-consult comes in, we're able to see, and our reception team are able to see what else it is that patients may be due for, especially now, early on in the financial year. For example, if patients due for smears, diabetic checks, anything else, we're able to book them in at the same time, as well as triaging whatever request that they've come in with. And finally, making use of those community services. So as part of the PCN IIF targets, we've got the community pharmacy consultation service, and it's very easy now when you have an e-consult and it's something that can be dealt with by a pharmacist to triage it via that route. And we have upskilled our care navigators to be able to do this. And although e-consult has its own level of built-in triage where it will try to direct patients to other services as they're filling in the form, it's not perfect, and we're now able to manage that triage better, and direct them to dentists, opticians, IAPT, whatever the community service is. We have a directory of those clinical services, and patients are now able to go to the most appropriate route faster. I will say, however, that there is no perfect solution, and I think my colleagues earlier will have mentioned this as well. The demand in general practice is obviously exponentially high, and when you offer patients a service like this, where they're able to send in a form constantly, theoretically a patient could submit an e-consult every day, and we do have some patients who are very high users of e-consults. However, it does allow us to manage that demand better, and we're able to group problems into. We're able to group patients and triage them more effectively rather than them contacting us every day. The initial onboarding of patients is also very difficult, especially if your patient population isn't very digitally literate and they're not used to using internet tools for NHS services. And we had the same problem with getting patients onboarded with repeat prescriptions online or the NHS app. However, this is something which is more of a short-term problem. Once the patients are onboarded and once the staff are on board and ready to use the system, then it's much easier for once they've gotten used to the system to then use it again and again. And like I said here again, with an ethnic minority population and non-English speakers, many of them will genuinely be unable to complete the form. And for that reason, we've been able to unlock more reception time. So our receptionists can guide them in completing the form, or in those cases, take a message, fill in the eConsult Lite, which I think is a platform that eConsult have developed for reception staff to fill in on behalf of patients, and use these other tools. And although I did mention demand management as an advantage, it's also in some ways a disadvantage, because our duty doctor's role is now significantly increased. We have a workflow for the triage process, but that triage process also needs a workforce to staff it. We do need care navigators and duty doctors who are able to triage them and do that within the time frame. And we've been able to achieve this or mitigate this by restricting opening hours and managing the patient flow. The data from eConsult is quite limited. We get weekly insight reports. However, we've not been able to see like an overall general trend, but we've been using it since June 2020. So it's coming up to almost 3 years now, which is a very long time. And in the last financial year, so in the last year from April to March, we processed over 3,600 eConsults, which is a vast number. We wouldn't have been able to imagine doing that, pre-pandemic. And on average, we get 45 to 60 eConsults per day. It's closer to 60 on a Monday and Tuesday, and then it maybe does level out later on in the week, but it will be it's a significant number of eConsults. One of the benefits, however, of this traditional tool is that we get emails weekly, which gives us a breakdown of the number of patients that have been using eConsult. So the number of visits that we've had, you can see in these 9 blue boxes underneath. So the number of eConsults that were submitted. And most interesting is the boxes at the bottom, those last 3, where it says eConsults diverted to other services. So, for those 12 patients filling in a form, the e-consult tool itself would have directed them to a community service that may be able to manage their presenting problem better, and also estimated appointments saved. So these would have been e-consults that or patient requests that we would have received, but now haven't because of the digital triage within e-consult. And then, of course, once we receive the e-consult, we have our own level of triage. So it's all about getting patients to the right place the first time, rather than them seeing a GP or a clinical pharmacist and then, being directed onwards. This is an overall case study that we built in conjunction with the Digital First team, and it goes into a bit more detail about the problems that we were having pre-pandemic and some of the benefits that we've seen now. So this will be part of my slide deck for you if you would like to have a read of it later. And I will be more than happy to answer any questions that you might have.
Thank you so much, Ishwir. That's really helpful and really good to see all the different aspects of work that's been taken to get this working, especially with such a diverse community with a non-English speaking background as well. So really good to see all of that working. I'm going to come on to questions in just a moment. I want to take a couple of seconds just to showcase the Online Consultations handbook that has also been created in conjunction with all the work that's going on at the moment around online consultation. So hopefully a lot of people have seen this already. It's been socialized as far and wide as we can, but if you haven't, we will be sharing the link to this. So this consultation guide is available on our futures page, and it goes into a number of different factors that will go into providing effective utilization of online consultations. So how to engage with your patients, your online presence, looking at managing demand, how to procure a system that's right for your practice and your patients, and also in the future, if you're feeling confident enough, how you can work more collaboratively as part of a hub as well. It's very interactive, so you can click on any of the areas and it will take you to that section. And I just actually want to highlight the online presence bit, because we do go into some of the detail on how you can make a better experience for your patients using your websites. We've seen that it's a very mixed economy on websites, and how the online consultation tool is promoted. So we've gone into a little bit more detail on how you can make it look a bit more effective and different options you can use. And there is a footer at the bottom which will take you to any of the different sections rather than trawling through the whole document from start to finish. In the introduction as well, just to highlight, there are case studies as well in here, further ones, just because there are so many different versions of online consultation systems being used and different methodologies behind the way the patients are triaged. So we want to just highlight a few more case studies in here as well. So there's a lot of information in here that really is really effective and hopefully will be useful to you. So we will share that at the end of this this session. So just wanted to do that as well. Okay, I will open the session up to questions. Does anybody want to come on to the call and ask any questions from our colleagues, our guest speakers here? And I'll have a quick read through the chat if there's anything else that's come through. Or is everybody still having their lunch at the moment? Matt, go for it.
That was really great from both practices on your journey and being really open with all the challenges that you've got. I'll keep my questions just to one. In terms of the training of the reception staff, I suppose into care navigators, or how have you both approached that in, I suppose, upskilling your sort of admin reception staff to take on more responsibilities? And I suppose how have you approached that, and any ongoing training reviews and challenges?
I think when it was first introduced, there was an extensive training, and it's extensive with the reception team, with documents kindly all produced by Devon, which must have taken hours and hours, literally spinning into urgent triage, same day, your routine, And then, but also with the knowledge that they can always ask. So it's not like you stick to that and that's it. There's a collaborative team that they can ask. And the weird stuff that, you know, don't be afraid to change your process. We had to change the way we did our triage with images because dermatology is tricky. And what we found is you can't have a receptionist triaging a dermatological issue from an image. So we've had to basically, what we put in the doctor's box, we've made a list of things that we think are clinically appropriate to do it that way. So you will find that you change your process over time, because simply you'll hit the level where you can see where the reception or care navigation team are comfortable at. And you'll get to the point where they start to recognize, because they do it over and over again, they almost they don't train themselves, but they retain that knowledge, and that knowledge just grows. But you will always find points where they'll go, oh, I know this doesn't sound quite right, but I don't know why. And that's where you need to bring your duty team in, or duty doctor, or an assigned person that they can bounce off.
The two things I would say on that is we did, I mean, it said extensive, but actually we did one Teams-based session, really, and we did it on Teams, partly because we were in the pandemic and partly because you can't get a whole reception team in one room at one time because obviously often working. And we really did it with the care navigation signposting exercise, and the tool that we put together is being shared, forms part of the online consultation handbook that Roman just shared. And I think the main thing, if you're going to have reception-led triage, is that there has to be a totally no questions asked, no qualms escalation policy. So it's very easy for them to just pop and assign a query into another box with what their query is. They don't have to come and knock and interrupt someone who's busy. And they can also pick up the phone and say, I've got someone standing in front of me and I'm not quite sure what to do with them. And when we assign it back, I try and explain my justification. So if they've sent me 3 things that sound similar, and one I've said add to the duty list, one I've said routine, and one I've said go to another service, I try and write in there why I've said that so that they are learning for next time. So say, actually, I really didn't like the look of this because of that, so can you add them on the duty list? They said that was going on for that long. So I think for me, it's about openness and there not being any barriers. If it's not going to be a clinician, then from a clinical safety point of view, it's got to be really easy. And I know that some practices do it the other way around. They have all
whilst Devin comes back in, I'm just mindful of time. Ishvia, I don't know if you had anything else to add from your side on training.
Yes, I mean, it's very similar to. Oh, sorry.
Oh, sorry, we lost you again, Devin.
You go, Ishvia.
Yeah, before we run out of time.
Yeah, sorry, no, I was just going to echo what you said. Our triage is quite clinically led. So we have a duty doctor who triages all of those e-consult requests. Because we think at the moment that is what is most appropriate for us. But I can understand the challenges that you might have having an admin-led triage, which may be the way we have to adopt or adapt our triage based on, as we get an increasing number of e-consults, it may be something to consider. And I should say I'm joined by Dr. Sangera, who is one of the GP partners, who is one of the triagers of e-consults. And so, yeah, so she will have a similar idea of the ways in which our e-consults are.
Yes, hi. I'm Vichita Sangera, and I'm one of the clinicians at Southall Medical Center as well. And yeah, so exactly as Ishvi said, it's mainly duty doctor and it's clinician led, but as the reception, are taking the messages and everything, we are training them, as my colleagues have said before, on an opportunistic basis, on a daily basis. It's actually working very close together now. The team is. It's not. This is reception. This is admin. This is clinicians. It isn't like that anymore. We are just working so close together now. So they ask us questions, and it's an ongoing training. Obviously, in the beginning, it was very robust training via Teams. When we could meet up face to face, we did it in house. But it's the triage, ongoing clinical meetings. you know, our career navigators are attending those as well. Practice meetings every time, monthly meetings. We have an agenda on upskilling the career navigators on signposting and clinical triage. So it's basically, you know, duty doctors are available to the reception team for advice and guidance. I think that's why we feel it's working quite well.
Thank you.
Thanks.
Thanks so much, all. I see Osman's got his hand up as well, so I'll bring Osman in.
Yeah, thanks. Very, very helpful. And I think I really like the right person first time approach, because I think that message is good for patients as well. I think just a bit of learning we've done in North East London, and something a lot of practices have implemented that we also do, is the fact that the triaging clinician is in the same room as the reception person, because I think that's really added lots of value to the quick queries that you don't have to message each other on. And yeah, that's positive we noted as well.
Yeah, definitely. Thank you, Osman. Okay, any other questions? No, okay, well, brilliant, thank you. Just to note that Tara has shared the Online Consultations handbook within the chat. So if you want to check that out, you can check it out there. We do also have a quick feedback form, so I've just shared that into the chat as well. If you could please go through that, that'd be really helpful to us, because we really want to understand how we can make these lunch and learn sessions useful for colleagues and guests, and some of the topics that you'd be interested in finding out a bit more about as well. And we can do the groundwork in finding people that are doing some good practice in the background. Okay, we've got a minute to spare. I just want to say thank you to Ishvia, to Anushka, to Devin, and to Vichitar as well for your input today and your presentations. It's been really helpful to understand a little bit more about the actual on the ground, how you're running the systems, and the benefits and some of the challenges that you're seeing as well. I think both benefits and challenges probably echoed across different ICBs and across different patches where different systems are being used. But if there are any questions from colleagues, then please do get in touch with us. We're really interested in hearing other bits of good practice, or if there's particular challenges you're facing that we might be able to help with as well. We're here to listen and to help and to support as well. So thank you for joining in through this lunchtime session. It's been really informative for me, and hope you found it informative as well. And once again, thank you to all our guests as well, and have a good rest of the day. Thank you so much for your time.
Thanks for having us.
Thank you.
Thank you.
Take care. Bye-bye.